We have just a few minutes for a couple questions. I know this is a topic that is obviously of concern to all of us. Real quick, Dr. Karp, for those of us who don't have access to sort of all this, the fancy technology that you have, what sort of are there commercial devices that are available that we can also utilize in our practices?
So I I have no commercial interest, the OptiView systems, either ArtiView, which is quite inexpensive at around 40, and the Avanti, which is just faster and fancier. But all of you have OCTs in your office that you use for the retina, and you can talk to your rep about getting an anterior segment adapter and start playing around and looking at the ocular surface. Some are better than others, and some will give it to you free. Some you may have it already, and others can be, a few $1,000s. But it is something that is now available to use. Yeah, it's great.
Yeah, please.
So I just want to ask Farouz or Carol Karp. Carol Karp, to start. You mentioned in your talk that there was a 20-year-old patient with squamous neoplasia. What was the underlying condition in that case? Why did that 20-year-old get squamous cell carcinoma?
So the first case that I presented, that patient had HIV.
Okay.
Yeah.
Has anyone seen vaping-related squamous cell carcinoma? We have a case of a kid who was vaping 5 years, 5 times a day, and developed just like what you had. It looked like band keratopathy, but it was squamous neoplasia, and we think related to vaping. It's something to be on the lookout for.
We also have a case that we're presenting, my research fellow is presenting, the case of acanthamoeba keratitis, which then, because of chronic inflammation, ended up, a 25-year-old developed squamous, ocular surface squamous neoplasia. Chronic inflammation, chronic irritation, HIV, all those things are factors.
Terrifying. Okay, next question. This one's for Dr. Ismaili. The question is, you have these patients, and with lymphoma, they've maybe responded partially to radiation, but there's still a little something there, and they're asymptomatic. There's no other orbital extension. There's no other systemic involvement. How aggressively do you go after those? Is there a role in just observation for those asymptomatic lesions?
Yeah, I think good question. Regardless of the dose of radiation used, even in the days that we were using the standard full dose, there are patients that end up with partial but very low volume, residual low volume remaining. And I have observed them for many years. There are some patients who absolutely refuse treatment, even without treatment. We have observed them for many years. I think the most important thing is to not lose sight of it getting outside of the eye, which is a low possibility, but still. So some degree of workup for CT of chest, abdomen, and pelvis once a year might be a good idea. But beyond that, for very low volume conjunctival disease, I do have lots of patients that we watch. One other step one could take would be a PET scan to see how metabolically active the degree of residual lymphoma is. But again, for small volume conjunctival disease, it likely will not have a high yield. So yes, I do watch them.
And how quickly after radiotherapy do we expect to see shrinkage of those lesions?
Rather rapidly, some within a week or two, but we expect some response up to 6 months. So some continue to respond up to 6 months.
Great. And this question's for Dr. Dalvin. For PAM, the question is, does it respond to topical chemotherapy? And then is there a role for that with large, extensive PAM lesions?
Yeah, I think absolutely there's a role, especially mitomycin C generally does quite a good job of melting away that pigment so we can chemo reduce. You have to be cautious because we want to know whether or not we're really dealing with malignant melanoma. So there's always this question of, should I try to get tissue so that I have a diagnosis so that I know how I'm going to systemically follow this patient if they truly have a malignancy and not just PAM. So if there is a localized area or a nodule, I would really strongly encourage biopsy of that, but certainly chemo reduction can spare us things like limbal stem cell deficiency and symblepharon.
And what's your regimen for mitomycin C, for instance?
Yeah, so I would use a QID typically for anywhere from 7 to 28 days. So I'll often do 1 week on, 1 week off, and then 1 week on.
And then for Dr. Shields, you mentioned doing a fine needle biopsy of an iris melanoma. Is there any concern of seeding? We were always talked about, being worried about that.
Absolutely. So if you have a pigmented lesion on the iris and there's unequivocal documented enlargement looking like a melanoma, you might not need to do a biopsy. But most of the cases, we actually do the biopsy just to confirm and justify treatment. And the treatment is generally either resection or plaque radiotherapy. You're always worried about seeding the tumor. However, if we're doing plaque radiotherapy, any seeds that get out, we can generally cover with the plaque.
Great. And maybe for the entire panel, or the question is really, you think you've got one type of lesion, you do the excision, and maybe your margins are still positive or there's deeper invasion than you were anticipating. What's your next step?
Yeah, I would take this question. As far as OSSN is concerned, if the margins are positive, we would consider topical chemotherapy following a surgical excision. But if the base is positive, we know that it's invading. So plaque brachytherapy, as shown in one of the cases that I presented, would be an option. Yeah, so is melanoma, as Dalvin has mentioned.
So it differs depending on your diagnosis. If it's squamous cell carcinoma, I agree with Farouz, and the margins are positive, we'll just add interferon after surgery, after the patient's healed up. If it's melanoma and the margins are positive, you really have to go back in and get clean margins. There's no topical therapy for that, and positive margins is a risk factor for tumor recurrence, so you don't want to deal with conjunctival melanoma recurrence. You go back in surgically.
And you just take everything that you think you see that has slightly pigmented, or?
Yeah, this really requires a very good slit lamp examination. We make large 8.5 by 11 drawings, like Dr. Dalvin mentioned, just marking out everything. And then when we go back into surgery, we remove everything that was suspicious and then reconstruct with the amniotic membrane.
Great. All right, that I think will conclude this panel. I'd just like to thank all my panelists. It was great talks, great discussion.